buenas tardes, buenas noches, en algunos casos, no muchos de Latinoamérica. Bueno, Ismael Cordero desde Uruguay. Es para mí un grato placer darles la bienvenida a todos ustedes. Siguen entrando producto de la aceptación en la sala de espera personas, así que estamos ganando unos segunditos para estabilizar todas las conexiones. Bueno, en nombre del Comité de Educación Continua de ALASBIMN, en particular es un enorme placer contar con todos ustedes nuevamente, con su presencia, para este nuevo evento de este ciclo ya conocido por muchos de ustedes, que se denomina Ciclo de Conversaciones con Expertos, el cual se realiza mensualmente a razón de una vez por mes, con algún tópico que está haciendo hincapié de mucho interés en las diversas temáticas que reúnen a toda nuestra profesión dentro de la medicina nuclear. Este en particular fue coordinado por la doctora Ana Rey, que ya va a hacer uso de la palabra, y va a ser moderado por una excelentísima compañera y amiga del Comité de Educación Continua, la doctora Amelia de los Reyes. Recordar a todos ustedes lo que siempre mencionamos al inicio de estos ciclos de conversaciones: los mismos son grabados, por los cuales tienen que apretar el botoncito de aceptar grabación. Los mismos son difundidos en modo asincrónico en el canal de Educación Continua de YouTube, a razón de unos 10 días después de realización de la actividad. Y bueno, como siempre, les pedimos a todos ustedes que participen activamente durante el desarrollo de la magistral ponencia, mantener los micrófonos silenciados para evitar esos problemas de interferencia en el sonido de las conexiones. Pero una vez terminada la ponencia, ustedes van a poder hacer uso de palabra y mantener siempre esos minutos que tanto enriquecen de intercambio, de diálogo interdisciplinario de los distintos profesionales que están aquí presentes el día de hoy. También, a medida que la presentación va transcurriendo, ustedes pueden, si quieren, para no irse olvidando, ir dejando alguna pregunta a través del chat, que bueno, las recopilaré y Amelia moderará para el excelente ponente que tenemos el día de hoy. Por mi parte, simplemente como secretario del Comité de Educación Continua, darles las gracias por la presencia el día de hoy, la persistencia en este ciclo de conversaciones, el interés demostrado mensualmente, que realmente para todos los integrantes de todos los comités asesores de las BIM es un gran privilegio y honor poder generar estas instancias de participación. También siempre están lo que decimos aquí en Uruguay, entre comillas, chivos, las publicidades. Próximamente empezaremos a hacer difusión del primero de los cursos que el Comité de Educación Continua va a coordinar y desarrollar a lo largo de este 2024, así que estén atentos a la página web de las BIM, a los canales de difusión y bueno, a sus correos electrónicos personales, porque todos están incluidos en la lista de difusiones. Sin más, desde Uruguay, deseo que tengan un excelente ciclo de conversaciones del día de hoy, que lo va a ser. Y bueno, no tengan miedo en generar sus preguntas y el debate a posterior. Le doy la palabra a Amelia y a Ana. Por mi parte, estoy aquí para hacer el soporte en todo lo que sea necesario. Que tengan un excelente ciclo.
Buenas tardes, bienvenidos. Soy Amelia de los Reyes, médica nuclear de Colombia. Voy a estar dirigiendo o coordinando todas las preguntas, entonces por favor siéntanse en libertad de hacerlas. Ahora los voy a dejar con Ana Rey, que es una química farmacéutica muy importante, muy conocida por todos, que es la cabeza del Comité de Radiofarmacia, que se va a encargar de hacer una introducción de nuestro excelente expositor.
Bueno, buenas noches a todos. Muchas gracias, Ismael, Amelia. Es un gusto en nombre del Comité de Radiofarmacia de las BIM estar participando de este ciclo organizado por el Comité de Educación Continua, en particular en esta ocasión con un tema de radiofarmacia y con un tema de gran relevancia. Todos sabemos que la medicina nuclear requiere para su desarrollo contar con radiofármacos que cada vez son más específicos, cada vez están dirigidos a blancos moleculares más específicos vinculados a enfermedad, y en particular desde mi perspectiva, que me dedico más que nada a radiofarmacia en tecnecio, el tener un desarrollo regional de un radiofármaco de tecnecio 99 metaestable, que ha cumplido con todas las etapas, desde las etapas de investigación básica hasta llegar a la clínica. Eso es muy importante y en particular es muy importante que se realice también en nuestra región, que no solamente recibamos productos desarrollados en los países centrales, digamos, sino que nuestra región también tiene capacidades y también tiene personas con la formación y con el interés en hacer estas tareas. Entonces, tenemos en la noche de hoy al doctor Sergio Souza de la Universidad Federal de Río de Janeiro, que nos va a estar hablando de justamente una investigación que va desde la base hasta la aplicación clínica de un anticuerpo marcado con tecnesio 99 metastable dirigido contra el factor de necrosis tumoral, particularmente aplicable en inflamación y en patologías de esa naturaleza. Los dejo entonces con el doctor Souza, a quien le agradecemos su participación. Y yo lamentablemente no los voy a poder acompañar en toda la conferencia porque tengo que dar clase. Justo hoy tenemos el curso de radiofarmacia de Uruguay y por eso, bueno, me despido acá, los dejo con el doctor Souza y bueno, yo también aprovecharé la grabación para luego poder ver en detalle la conferencia. Doctor Souza, tiene la palabra.
Gracias. Buenas noches. Me gustaría agradecer al Comité de Educación Continua en la persona de la doctora Amélia de los Reis y al Comité de Radiofarmacia en la persona de la doctora Ana Rey por la invitación. Lo siento, no hablo suficientemente bien el español para dar la charla en español, entonces hablaré en inglés. Well, we are going to talk a little bit about entity and scintigraphy. I have no conflict of interest for this lecture. As it is known, TNF is a pro-inflammatory cytokine with important roles in immunity, inflammation, control of cell proliferation, differentiation, and apoptosis. Its recruitment and activation occurs mainly by macrophages, although it can also be produced by lymphocytes, natural killer cells, neutrophils, and monocytes. Studies have shown that TNF can act differently depending on the situation, initiating or sustaining pathological inflammatory states or acting in an immunomodulatory or disease suppressive manner. This can be in part explained by the diverse functions that TNF receptors have, as well as by the differential activities of their soluble and transmembrane forms. TNF blocking agents have been used successfully in many diseases with inflammatory and or autoimmune components. There are many anti-TNF antibodies in the market, such as Humira, Remicade, Symphony, Cimzia, or Enbrel. We have used Humira, a humanized monoclonal antibody, in all of our research. Unfortunately, I won't be able to give many details of the labeling process because it is patent protected, but I can say that we have reached the high labeling efficiencies above 90% and excellent in vitro and in vivo stabilities. Many hours after label, it is still stable. Regarding our preclinical work, it was constructed using both human gamma cameras in the beginning and more recently animal-dedicated machines. Here we can see the normal biodistribution of the anti-TNF labeled with technetium in a rat, which is basically composed of the liver. Here we can see the liver. And here we can see a clinical translation to a healthy individual where we can see the liver uptake, but we can also see the kidneys, which are the excretion route for the radiopharmaceutical. This is a 1 hour post-intravenous administration image. we have used the anti-TNF alpha scintigraphy in many diseases, including rheumatoid arthritis, growth ophthalmopathy, psoriatic arthritis, ankylosing spondylitis, autoimmune enteropathy, inflammatory bowel disease, and more recently, in either hidradenitis suppurativa. And what we found to be the major role and application of the anti-TNF scintigraphy was to monitor disease activity and therapeutic response. So let me start showing you an example of a comparison of the uptake of the radiopharmaceutical at a healthy volunteer and a rheumatoid arthritis patient with active disease. In the wrists and in the hands of the healthy volunteer, we can see no uptake at all. These hands are mine, so thank God it was really negative. And here we can see at the patient with active disease, a punctual uptake at the base of the second metacarpal bone and fourth phalangeal of the right hand. And we can also see a mild sparse uptake at the carpal bones of both hands. Our first work on rheumatoid arthritis was one comparing the use of radio-labeled human TNF scintigraphy with clinical examination and MRI of hands and wrist joints in patients with non-active disease. We have studied 8 patients comprising 198 joints, where virtually there was no difference in signs of inflammation detected by MRI or scintigraphy. And they agreed with negative results for 145 joints. Scintigraphy reached 89.8% of sensitivity and 97.3% of specificity. In conclusion, we have seen that scintigraphy using anti-TNF alpha showed a high correlation with the presence of inflammatory signs detected by MRI in the hands and wrists of patients with active rheumatoid arthritis, and also demonstrated a greater sensitivity than clinical examination. Here, we can see the clinical evidence of a right hand fourth proximal interphalangeal joint swelled with correspondence with the scintigraphy and the MRI. But during submission of this article, one of the reviewers questioned us whether or not it was occurring a specific targeting of TNF at the sites of the swollen joint regions. And then to prove it, we have tested the TNF scintigraphy 1 day after the patient had received the cold anti-TNF alpha therapy, and then repeated this patient in the 7th day. And here we can see a huge difference in the uptake of the radio-labeled anti-TNF, proving that at D1, the first day post-cold TNF, where there should be the radio-labeled anti-TNF, these places, the sites were occupied by cold anti-TNF. And 7 days after that, these sites were no longer occupied by cold anti-TNF, and the radio-labeled anti-TNF could reach it. And then we proved it was a specific uptake. Here we can see a patient that didn't respond to treatment with anti-TNF. You can see that there's just a little decrease comparing the different images, a little decrease of uptake at the joints of these hands. This is another article where we have tested the anti-TNF scintigraphy for the detection of inflammatory activity in rheumatoid arthritis where we have included now 220 joints of 20 patients and reached 79% of concordance, but an accuracy, sensitivity, and specificity of 92, 89, and 92%. So we could conclude that anti-TNF scintigraphy had a good ability to distinguish between inflammatory and non-inflammatory lesions in patients with rheumatoid arthritis. Another disease that we have studied was Graves' ophthalmopathy, the most prevalent extrathyroidal clinical manifestation of Graves' disease, which poses a challenge for doctors regarding inflammatory activity. So here we have studied a case of a patient with active unilateral Graves' ophthalmopathy, comparing two radiopharmaceuticals, both labeled with technician, an anti-TNF and an anti-somatostatin receptor octreotide radiopharmaceutical. And we can see here a huge uptake at the right orbit, 30 minutes after intravenous administration. We were very glad that this image was awarded with the front cover of the journal by that time. But the inflammatory activity remained in our heads as a challenge. Then we start to think about how to distinguish patients with positive clinical activity score from patients without inflammatory activity. Then we thought about running a visual and semi-quantitative analysis, making a relationship between the uptake of ROI from anti-TNF alpha, labeled with technician, at the orbit and the occipital bone. In order to do that, we try to define which ratio would mean lack of activity and which ratio would mean inflammatory activity. To do this, we have studied 25 patients in different inflammatory stages and 10 healthy volunteers. So we could establish that positive scintigraphy was positive when the ROI was above 2.5. In addition, uptake for each positive exam was scored as either slight, moderate, or high. And we have studied 69 orbits, which 38 came up as positive. Comparing the data, we have reached a high sensitivity and negative predictive value. However, the specificity and the positive predictive value were 71 and 68%. Here we can see an example of a positive and a negative analysis. And here we can see how we do it. Let me stop it here to show you. So here are the ROIs for the orbit and for the occipital bone. And then we've done the ratio among them. And here at a negative study, here the ROIs and for the orbits and for the occipital bone. Well, continuing this study, we tried to determine whether or not scintigraphy could predict response to corticotherapy in chronic active Graves' ophthalmopathy patients. Here we evaluated 18 patients, comparing responders, which are patients that became inactive, and non-responders. From the 31 orbits that concluded the study, 18 responded to corticosteroid therapy, 6 maintained clean inactive, and 7 didn't respond to therapy. Scintigraphy showed a good association with active eye disease and maybe an additional tool to identify corticosteroid responders. Here, we can see an example of SPECT MRI fusion showing an uptake at the right orbit in the topography of the inferior oblique muscle. Well, another disease that we have studied was psoriatic arthritis. Here we have shown for the first time, and to the best of our knowledge, the presence of TNF-alpha in the skin of a patient using imaging methods. Here we can see the hands and wrists showing erythematous plaques. The planar scintigraphy showing uptake at the second metacarpophalangeal joint, MRIs, and a SPECT showing dermal and articulation of the right second metacarpal uptake corresponding to the gadolinium sign of the MRIs. We were also granted with the front cover of the journal with this work. Here we can see other examples of anti-TNF scintigraphy in psoriatic arthritis, in the feet and in the elbow. Here we can see the plaques all over the arm and the corresponding scintigraphy. Another disease that we have also studied was ankylosing spondylitis. Here we can see a case of a 47-year-old female patient complaining of low back pain inflammation, which began 4 years before her condition has exacerbated to morning stiffness and anterior uveitis in the last 6 months. Initially, she was diagnosed as mechanical low back pain. She irregularly took non-steroidal and anti-inflammatory drugs and corticosteroids. But here we can see an increased uptake of the anti-TNF-alpha labeled with technician in an area corresponding to the topography of the ilium and the right sacroiliac joint. And here in the MRI, we can show a minimum impregnation of the gadolinium in the right sacroiliac joint and at the iliac face of the inferior third of the right sacroiliac joint. Here we have other examples to show an interesting point, which is the uptake at the anthesis when it is inflamed. And here we can see a bilateral enthesitis, which had a negative MRI. Unfortunately, I don't have the MRI to show. Regarding the autoimmune enteropathy, we have a very interesting case of a 32-year-old man with liquid diarrhea progressing to malabsorption syndrome despite different nutritional interventions and without a previous history of autoimmune disease. So the patient's doctor was wondering if there could be a response to an anti-TNF therapy for this patient. So we have done an anti-TNF scintigraphy and have observed a diffuse uptake at the abdomen, more concentrated in the bowel topography. This result encouraged the doctor to treat the patient with adalimumab, and 4 weeks after the initial treatment, we have repeated the anti-TNF scintigraphy and saw a huge decrease in the bowel topography uptake. This patient follow-up was great. He is fine till what we know. We are also testing anti-TNF scintigraphy in inflammatory bowel disease. Here we have an example in a patient with Crohn's disease, where we can see diffuse uptake at the bowels. And here we have another example with also of inflammatory bowel disease, but with a curious finding of an associated orchitis. Here you can see at the whole body image, and here at a spot. It was really interesting to find out that. Well, the last disease we have recently studied was hidradenitis suppurativa, which is a non-contagious skin condition with chronic and severe complications, such as abscess and scar, mostly located in the axilla, groin, perianal, and/or inflammatory folds. So here we can see an increased uptake in the scrotum and in the perianal and intergluteal regions. Let me show you a fusion where you can see better the extension of the disease. Let me play it again. Okay, so you can see there's a lot of uptake. And this patient would respond probably to an anti-TNF therapy. Well, as take-home messages, I think we could say that scintigraphy with anti-TNF alpha labeled with technetium can be very useful in evaluating disease activity in conditions that have tumor necrosis factor alpha in their pathophysiology, and scintigraphy with anti-TNF alpha can be very useful in selecting patients who are no longer responding to conventional drug therapy and who intend to initiate therapy with immunobiologicals. I'd like to thank all of the doctors, professors, patients, and students involved in these studies. There are a lot of people. This is a work of many hands, but I'd like to thank mainly to Professor Bianca Gutfili, which is the head of the lab and the leader of our group, and Professor Flávia Paiva, that started the studies a long time ago. I also would like to pay my respects to my friends and the people of Rio Grande do Sul that are suffering from this unimaginable tragedy here in Brazil. Muchas gracias.
Muy interesante, doctor Sergio. También estamos pues muy tristes viendo las noticias del sur de Brasil y sus inundaciones. Yo pues mientras nos dan preguntas los invitados, yo quería hacerte una pregunta. Nosotros aquí en Colombia no tenemos ese medicamento, me imagino que tú lo desarrollaste desde el inicio. Utilizamos octreótido marcado con tecnecio u octreoscan. ¿Tienes algún estudio que compara esos dos medicamentos o radiofármacos?
Sí, me voy a responder en inglés, ¿ok?
Está bien, sí.
In our study, in this one that I showed, we have compared both octreotide and the anti-TNF. You can see that there's uptake with both of the radiopharmaceuticals, but what we have learned is that Graves' ophthalmopathy expresses more TNF in its in the surface of the membrane of the cell than somatostatin receptors. But it's possible to do. There are some specific for Graves' ophthalmopathy. There are some works in the literature showing that it's possible to use the octreotide. It is more favorable to use the anti-TNF in rheumatoid arthritis and inflammatory bowel disease. Disease that really have more TNF in its pathophysiology.
Muchas gracias. Y una segunda pregunta que te tengo. ¿Cómo lo usan ustedes? ¿Ustedes tienen una patente, tienen un registro sanitario del medicamento? ¿Lo pueden vender a otros países?
Yes, we have a patent, but we are still in what we call, we have done still a phase 2 clinical trial. We need to have more patients, although we have in a totality of maybe something like 100 patients, adding all of the disease that we have studied till now. But we need more work to put it forward and became to really in order to sell it. We are a small lab. We've done all of it as a research, but we are open to proposals, of course, to put it for higher sets.
Perfecto. Pues no nos queda más que felicitar al grupo. Es un trabajo excelente, doctor, sobre todo que digamos que estas son como unas patologías que no han sido muy estudiadas, han estado abandonadas y para la gente pues es algo que los hace sentir muy mal. El estudio de la inflamación y la mala respuesta a la inflamación y el dolor son algo muy importante para estudiar en la actualidad. ¿Alguien más que quiera hacer alguna pregunta? ¿Alguien que quiera hacerla de modo hablado o escrito? En el chat no veo ninguna pregunta. Bueno, entonces, Sergio, ¿quieres decir unas palabras de despedida en el idioma que quieras?
No, I'd like to thank for the invitation. Sorry, I don't speak Spanish, but I'm trying to learn it. Acá em Brasil falamos que hablamos portunhol, que é na mistura de português com espanhol, but they have many people from different countries, I thought it was better to speak in English.
No, it's very clear. Thank you for everything. And thank you for your participation. And have a good night for everyone. And goodbye.
Thank you.
Thank you.
Bye bye.
Muchas gracias.